Yeah, thank you, Pastor. Okay, Lisa asked if I'd come talk a little bit about the biological elements of addiction. And I think probably one of the biggest challenges that we face as a culture is a grave misunderstanding about some of the physiological mechanisms of addiction. And even people who are really early in recovery will fall into the trap of thinking that willpower is enough. And many people will be shamed or stigmatized with addiction because we can easily look at them as a culture with those who struggle with addiction and say, well, they're just not trying hard enough, or they're just not motivated to stop the behavior. And we really don't have a good understanding of what that means physiological to be able to stop the behavior. And so I want to just share with you just a very kind of basic college 101 level of some of the mechanisms of addiction. Am I coming across pretty loud? Okay, I can't tell if I'm speaking too loud or too soft. So, let's see. There we go. So first of all, Lisa didn't pay me anything, so no conflict of interest. I'm not going to say anything that's going to build up Lisa. When we look at the problem of substance abuse, and compare it to other mental health conditions, and many of you may work in a pastoral setting or a 12-step setting, and we have people who come to us for a kind of life counsel or coaching or just guidance in a lot of different capacities. And one of the things that makes most conditions that people come to us for help with when we're acting any kind of role as a counselor is they come to us motivated by the desire to eliminate the suffering that they're carrying. And so they're internally motivated because the elimination of suffering is the goal. So when somebody comes and they're struggling with anxiousness and worry, or they're struggling with depression, and their heart's very, very burdened by it, the elimination of that is the reason why they keep coming back. And if you give them some guidance, if you give them some perspectives, if you give them some tools that can help them feel like they can manage their anxiety better, or manage their depression better, or manage whatever the life struggle is, they'll keep coming back because you're helping them reduce the suffering. And so traditional caregiving or therapy kind of works because the other person has initiated the treatment or they initiated the relationship. They attend meetings or appointments and they comply, or they'll at least try out the recommendations because they're motivated by eliminating their suffering. And that's pretty commonsensical, right? Now here we have the problem though with substance abuse. The problem with substance abuse is that it operates on a completely different dynamic. And that is, when people discontinue using substances, that creates its own physical suffering. And there's a lot of physiological imbalances that I'm going to talk to you about here in just a minute that create a discomfort and internal distress, or a lot of physiological symptoms of illness, like withdrawal symptoms. And that creates its own suffering. And so people will keep going back to the drug because it's only in the context of using that drug that they get rid of suffering. And so here we are encouraging them to stop using a drug that creates more suffering, going back to the drug, eliminate suffering, and no wonder we face an uphill battle as caregivers. So as a result, even in the mental health field, which is the background I come from, it's very easy for mental health providers to get very, very frustrated. We get high no-show rates with people who just don't show for appointments. When they do show for appointments, they're not very compliant in doing the exercises or the homework or following the instructions that we gave them. And our outcomes are not as good. If you take my experience and what the research shows in treating someone who suffers with anxiety disorders, let's say panic attacks. Anxiety disorders and panic attacks is a very, very treatable condition. And in fact, about 90 to 95% of people who seek treatment for anxiety disorders will come away with elimination of that condition. Substance abuse, we get 25 to 30% positive outcome rate, so much, much lower rate. And so as a result, helpers just decide, I don't want to work with a group of people that makes me look bad. Or I'm just sitting around because I have a lot of no-shows show up. And so many, many providers, even in my field of mental health, will say, I do everything but substance abuse. And they will, out of that frustration, we have kind of a segregated group of providers. We have traditional mental health providers, and we have substance abuse providers, because they operate with very different physiological mechanisms. So just to give you an idea of the scope of the problem, this is a few years old. I understand 2018 statistics have just come out, so I need to update my slides. But when I put this together a little over a year ago, I was using 2016 statistics, and 23 million Americans actively have a substance use disorder. So when you look at the overall population of the United States, which is right around 320 million, a little under 10% of the population struggles with a substance use disorder. That's very, very high. When we look at the problem at a lethality rate, we've got one person dying on average every 10 minutes. Now, this data is old, so it's actually, I think, going up because West Virginia has the highest drug overdose rate per capita. 51 out of every 100,000 people in West Virginia will die from substance use in a given year. That data, I understand, I need to actually look it up to make sure I'm accurate, but I understand from word of mouth that in 2018 we're up to 57 per 100,000. So our numbers are going up on a per capita basis. And we're still the top state in the country. I believe Ohio is now number 2, and they're in the 30s. So we're in the 50s, they're in the 30s in terms of number of people who die from overdose on a per 100,000 population basis. Neonatal abstinence syndrome, which is a big name for just basically saying babies who are born in withdrawal. We have a very, very high prevalence rate of that. So of 1,000 births, 44 are born in withdrawal. And that's a crazy statistic when we consider how many kids, and we don't even know what the ripple effect of that is going to be 20 years from now in terms of adult brain functioning when children are born in withdrawal and have to be weaned in the first few weeks of life. So that's just a horrific condition which speaks to the urgency of the problem that we need to be tackling. So I like to keep things in perspective in terms of how big the problem is. We rightly have a good recognition of veterans in our population. I'm a veteran. I've worked at the VA for a number of years. And one of the big populations is the veterans of the Vietnam conflict. And if you look at the total number of veterans who died in Vietnam was 58,000 total. So if you go to the wall in DC on the National Mall, you'll see about 58,000 names from that conflict, that war. In 2016 alone, we had 54,000 people die. That's 1 year. And we go to a lot of effort to try to help veterans from the Vietnam War. And if we put in just a little bit of that effort to help those with substance abuse and put it at the same level, wow, amazing the results we might be able to accomplish. So one of the problems that if you, as a peer recovery coach, as you as a parent, as you as a counselor, we run into is that we're going to run into a wall if we view addiction as a resolvable acute condition, like the flu. Somebody comes in with an inflammation of symptoms, we give them a certain protocol or set of instructions to follow and expect them to get better. And if we kind of have that mindset, we're going to be very, very frustrated. We need to change our focus from addiction as a function of willpower or just a constellation of behaviors to a chronic disease of the brain that affects behavior. So, addiction as a disease is just like any disease. It has a complexity of physiological measures, it has behaviors, it has treatment compliance, many different things. And what we find tends to produce the best outcome when we see addiction as a disease that can be managed through lifestyle changes. So when we say not cured, what we mean by that is that if I get chicken pox and I get after I recover from chicken pox, I can be around the chicken pox vaccine, or the virus, and not develop chicken pox again, because my body's developed an immune response to that. And we have all kinds of immunizations that are provided for a number of diseases where you get a little bit of exposure to the disease and then you're cured from getting sick with it again in the future. Addiction's not like that. Somebody could be clean 5-10 years and they go back and pick back up, and the body has an amazing memory to go back and take the person back to where they were. Which is why so many people, when they leave rehab, and they've been clean for some period of time, and they go back out, and they don't just pick up one beer. They'll go back out and they'll pick up right where they left off in terms of the intensity or the severity of their use, and which is sometimes why we see a high level of overdoses right after leaving rehab. And so people are not cured from the condition, but the condition can be managed long term. And so I like to refer to the term dormancy. So trees can go dormant in the winter, and they're not producing any leaves, but they're very much alive. And addiction is like that. We can help it go dormant, we can help it so that the person can live a very productive life, but if they get back in the same environment, they get back with the same ingredients in their lifestyle, the addiction can come back just as strong as it was when they left it. And so I want to help just kind of explain some of the neurobiological mechanisms and why that's the case. And it all comes down to a certain chemical in your brain called dopamine, which, if you wonder where we get the street name dope, it all comes from this, dopamine. Amazing chemical in the brain that God gave to us in His creation. It's a neurotransmitter in the brain, and it is a chemical that's kind of a communicator. Now, I want to give you a parallel illustration about how we have light in this chapter. We have two things that are being involved to give us light in here. We've got a power source that's coming in, we call electricity, and then we have the light bulbs that are receiving that electricity and being able to shine for us to have light. So we really have to have both things, both the generator of electricity and the receiver of that electricity. And our brains are very, very similar. We produce dopamine, and then there has to be a part in our brain that receives dopamine that can use that, just like the light bulbs receive the electricity from the electricity. When our brains are normally functioning and dopamine is coming from the power source inside the brain and being received inside the brain, we experience good feelings. We feel euphoria. We feel pleasure. We feel a sense of satisfaction or gratitude, empathy. All those positive emotions are a function of both the generation of dopamine and our brain's ability to absorb dopamine. So just like we have light in here that enables us to be able to see and to be able to enjoy this time together today, it comes from those two sources, the production of electricity and a light bulb that can receive the electricity. So what we're coming to find out in people who suffer with addiction is there is a part of their brain that receives dopamine, and these are called dopamine receptors. And there's an area in the brain that if you stuck a pencil in your ear and tried to pull it out the other, and for some of you that might be easier than others, you would go right through these areas of the brain called the nucleus accumbens and the amygdala. And those areas of the brain are very, very important for managing emotion. And what we see when we look at scans of brains of those who suffer with addiction compared to those who don't suffer with addiction is the dopamine receptors in addicts is very, very low. So to go back to our electricity analogy, it's like if you've ever gone into a room that was very, very dim, and you're like, why is it so dark in here? And you look at the light bulbs and you say, well, it's only got a 15-watt bulb. We need to put a 100-watt bulb. And then you change the light bulb out, and now you've got plenty of light. People who suffer with addiction suffer with like low voltage light bulbs. They're not producing much euphoria, much pleasantry in life. They're not experiencing it. And so when we don't experience that naturally on its own, we go to two places to get it. One is through substances we ingest, or two is from experiences we can have. So when we go jump out of an airplane and we're thrill-seeking, we're producing a lot more dopamine and hoping of brightening that light of more pleasure experiences. Or when I go to Golden Corral and I look at that dessert bar, all right, I'm getting that dopamine going because I'm going to enjoy all that food. I'm flooding myself with a lot of dopamine. And so we can increase our dopamine levels in our brain by substances we ingest or by experiences we can create. And individuals with addiction don't experience the same amount of enjoyment, at least this is the theory, from normal everyday events like family get-togethers, holiday celebrations, comedy or funny movies. And so there is beginning early in childhood an effort to be looking for some forms of stimulation. And so this is referred to as the dopamine deficiency syndrome. And so we find that individuals with addiction, or dopamine deficiency syndrome, have reduced dopamine release in the physiological pleasure centers of the brain. Okay, so give you some pictures here. So right here are people who don't suffer with addiction. And the red areas are dopamine receptors. It's kind of like the light bulbs in the light sockets. So they have high voltage, high bright light bulbs in their brains. And that's kind of why we say the phrase, the light bulb went off. They've got a lot of electrical activity going on. Now, if you look at these different level of people who suffer with addiction, a smoker has a little bit less dopamine receptors compared to the non-smoker. And so they're not, without smoking, they're not experiencing as much dopamine activity. The person who's an alcoholic has a lot less dopamine receptors. And then look at the person who suffers with cocaine or stimulant addiction, like crystal meth. We can see that that can also be one. Now, I've got another one up here, in obesity. And sugar or food can be just as powerful of a drug. In fact, when I was at the VA, we oftentimes joked about the VA tumor, and that is when people would get off of drugs and they would be in the program, they would, on average, gain about 40 pounds in 6 weeks. And just exchanging one drug from another. And so addiction substitution is a topic you may hear about, but this is the reason why. We just transfer from one substance to another, looking for something to give us more dopamine or to give us more power to the light, to get more brightness. Now, here's the problem that we often also struggle with addiction, and it works like this. So let's say that we're not getting enough power, enough lightness in here. Instead of changing the light bulbs, we say, let's get another power source. Solar power is in right now, right? That's kind of the thing to upgrade to. So let's put solar panels on the roof and see if we can get some more electricity. And so we turn on the solar panels, and we get in more electricity through solar power. And as we do that, we don't need the power from the electric company. So if the electric company sees I'm not using their electricity anymore, what are they going to do? Turn it off. I'm not using electricity. I'm getting all my power from the sun. So the electric company turns the electricity off, and then on a cloudy day, there's no power. I go back to turn on the electricity, and there's nothing there. All right, in a similar way, that's what the brain does as it adapts. As a person who suffers with dopamine deficiency syndrome starts using drugs, and their brain gets used to having the dopamine provided by an outside source, the brain stops creating its own.